Hi, everybody. This is Kristen from Vetmedology. I'm here with Brian, my other co-founder from Vetmedology, and we are going to be discussing at the Bandaging 102 advanced bandaging techniques with him tonight. So let's see here. Let me go ahead and start sharing my screen here, and we will go ahead and get right into it, okay? Let's see here. There we go. Okay. Okay, so about Brian. Brian started as an emergency veterinary technician at a specialty hospital in 2017 and began working in specialty surgery in 2019. He became credentialed as an RVT in 2020. Brian has taught veterinary technicians in the DC metro area how to bandage for 4 years. He founded Brian's Bandages in 2021 after discovering the lack of quality continuing education resources for bandaging in the veterinary field. He is now also a co-founder of Vetmedology, veterinary continuing education platform. All right, so now we present Bandaging 102, Advanced Bandaging Techniques by Brian Goleman. Take it away, Brian.
All right, thank you to everyone who's joining us. I really appreciate you taking the time out of your busy schedules to learn about some bandaging, and not just bandaging, advanced bandaging. Today, we're just kind of go over a couple of things that I felt like we needed to mention during Bandaging 101. And then we'll move right into the more advanced bandaging techniques, your fiberglass casts, your SPICA splints, your external fixators, your Ehmer slings, your vacuum-assisted closures, all the stuff that are just a little more advanced other than your just soft padded bandage with a couple of splints here and there. We're going to take it to the next level. So I'm just going to go over a Bandaging 101 recap right now. All right. So to begin with everything, I'm a big fan of tape stirrups. I believe that they are the most effective way to keep a bandage on. I'm not a huge fan of the elasticon at the top. I really like the tape stirrups because I feel like they adhere to the skin a lot better. They support the weight of the bandage using their own mechanisms. And overall, I've just had more success with them. Start bandaging below the toes so the patient's walking on the bandage, not the toes. This is one of the most common mistakes in bandaging, where people want to view the toes, so they leave them hanging out. If you take your 2 fingers and kind of just push down on a table, you feel a lot of pressure. It kind of hurts. That's what we're asking all of our patients to do when we're leaving our toes out. And that causes major swelling. And then that turns the bandage into a tourniquet effect, which causes blood flow loss to the limb, which causes the limb to potentially fall off. It's not a great situation, and it's easily avoidable if we just ask our patients not to walk on their toes by starting the bandage a little bit further below the toes. When wrapping the cast padding, you should have tension. It should never be loose. There are dimples on the cast padding, and when you pull it, you get rid of those dimples. That's what we're trying to do. You want to lay it down flat, and you want there to be tension. I know when bandaging, you're trying to find the correct balance between too loose and too tight. You don't want it to be too loose because then it'll fall off. You don't want it to be too tight because we don't want to cut off the circulation like we just talked about. So I've found that if you just get rid of those little dimples on the cast padding and just pull it tight enough to eliminate those dimples, then you're all set to go. Always an open-toed bandage unless the toes are involved. This is when we're talking about broken toes. We're talking about degloving wounds involving the toes. If those are involved, we want to protect the toes from the environment. So we'll want to do a closed-toed bandage, but everything else should be open-toed just so the owners can monitor for that at home. Now getting through that, well, I'm going to move on to the first advanced move. Our first thing, it kind of segues nicely from your soft padded bandage and caudal spoon splints. This is the exact same techniques as a soft padded bandage. We're just adding a fiberglass cast. So why would you use a fiberglass cast? These are for your tricky fractures that need a lot more support, your luxations, your tight incisions that you don't want the patient moving their leg at all, your SPICA splints. These are all things that involve fiberglass casts, and I love using fiberglass casts. I think when done correctly, they could really support the limb. And using this 3M brand is what I use at my hospital. I love it because it's dry in 30 seconds and completely weight supporting in 20 minutes. So usually by the time the patient is recovered and waking up, they can absolutely walk on it and it gives them the full support. Things you'll need: cast padding, cotton tape, fiberglass wrap, your vet wrap, your 2-inch cotton waterproof tape, and your stockinette. These are all things that you, for the most part, need for your soft padded bandage. But on top of that, your fiberglass wrap. All right, how to use it. So we're going to bandage the limb just like an open-toed modified Robert Jones. But once you get to the cotton roll gauze layer, that's when you're going to stop, and that's when we start the fiberglass cast padding. You're going to take it out, and you can either run it under hot water from the sink, or you could fill a bowl up with hot water and then just dunk it in. The goal of this is to get the whole thing soaking wet. You want it to be wet through every single layer. But when you're applying it, you want to wring out that roll and try and get as much water out as possible. The more wet the fiberglass cast is, the longer it'll take to dry. And also you don't want to get that cotton padded layer wet. So you're trying to get it soaking wet to soak the entire fiberglass, but then you want to wring it out and try and get as much water as possible. That's going to activate the fiberglass and start heating it up, and then it's going to dry really fast. Then you're just going to start wrapping it just like cast padding. You're going to try and do a 50% overlap going up, and then 50% overlap coming back down. You want to add at least 1 or 2 layers because I found that one is just a little too flimsy. So you're going to want to at least go up with the fiberglass cast and then come down with the fiberglass cast. At that point, that's when you're able to provide your patients with the most support. Then you're going to start wrapping from distal to proximal and then come back down. I usually, once I'm done with that, I'll wait, like I said, like a minute or two until it's dry to the touch and it's hard. It's completely hard. You don't want to try and cut or use your Dremel too soon when it's soft, because then it'll start manipulating the cast to a point where you're getting divots. You want to wait until it's completely dry before you start dremeling. At our hospital and at most ER hospitals, we like to bivalve the cast immediately. And I know what some of you might say, like, that's compromising the structural nature of these casts. But let's say an emergency happens and the nearest vet doesn't have a Dremel and they're unable to cut this bandage off. Well, if we bivalve it appropriately immediately and then wrap it in elasticon, it will stay structurally sound. But in case of that emergency, they're able to take off the cast without having to Dremel it or anything like that. Then once you're done bivalving, wrap it in elasticon a couple of times in a couple of places, and then finish bandaging with a tension-free layer, your vet wrap, and then finish bandaging just as normal. All right, this is a video I made. I'll kind of walk through some points. This is a small Papillon that had a fracture. Start wrapping as normal. You start wrapping below the toes, and then just work your way up. I always like using stockinette. The stockinette at the top is mostly for looks. I just think it makes it look really clean and pretty at the end. In these situations, it does add some padding when you fold it back down at the end, but for the most part, I think it's just aesthetically pleasing and just kind of gives your bandage that next level of appearance. Now we're adding the fiberglass. Like I said, start below the toes and kind of go up 50% overlap. You want to keep it below the cast padding at the top. You don't want it to go any above that. So I do 1 or 2 layers, wait for it to dry. You're just kind of sitting there. All right. I have a terrible eye, so I like to add a couple of lines to make sure that my Dremel is going straight and nice and even. And then I start Dremeling. All right, now that I've done bivalving, I add the elasticon just to lock it back into place. Pull down a stockinette and then just finish bandaging as normal. Pull up my stirrups. I like to put a pee pad down underneath because the Dremel creates a lot of dust from the fiberglass. And so I don't want it to get trapped into any of the vet wrap or all over the patient or anything like that. So I like to discard it, finish my vet wrap. Sure, it's an open-toed bandage. I like to use a tongue depressor to kind of separate the toe and the toe from the bandage, and I shove some tape down in there just to open it up. And then I just add one more piece of waterproof tape to finish it up and make it look nice and clean. And there you go, folks. That's fiberglass casts. All right, moving on to the next advanced move, SPICA splints. I do enjoy a nice SPICA splint. I think they can be pretty tricky because it's a nice combination of a full cast and a chest wrap. So why would we ever use a SPICA splint? So these are the fractures that are above the elbow or above the kneecap that can't be supported with a cast, a normal cast, because it's up too high. Usually we like to bandage above the bone that we're trying to heal. So if it's a humerus or a femur, we can't really go above that without doing a cast that involves a chest wrap or another abdominal wrap that kind of takes it to that next level. These are mostly used for temporary immobilizations of the shoulder or elbow or femur, mostly because surgery is delayed or the patient requires transport before fixation. These are never really used as a permanent primary management of humeral fractures. There's just so many better ways and so many factors that go into spicas that it's just not really worth it, unless like cost or something like that is involved. Surgery is usually the best option, but with these SPICA splints, it really inhibits their mobility. So it's really tough to ask a patient to do this for an extended period of time. Unless the fracture, I stay here, unless the fracture is a uncomplicated green stick fracture of a young patient that might heal pretty quickly, we do tend to avoid these bandages as a primary management. Application. So we're going to start bandaging at the digits. You're going to do your arm first, and then you're going to go bandage it like a normal bandage until you get up top. This is when you're going to start doing your figure 8 chest wrap around the patient's body. So you're going to try and do this in one motion just so it's all incorporated together. It's going to be bulky. It's going to be a lot of cast padding. You're going to want to start at the foot and then move all the way up and incorporate the chest. This is awkward because usually your patient is sedated. So it helps to have someone help lift the dog as you're doing a chest strap on a sedated patient. What's important in SPICA splints is you don't want to go in front of the non-bandaged leg. And by that, you don't want to inhibit their mobility with that other leg. So you want to make sure you're bandaging. If you're coming up and bandaging around here, you want to go behind and come down their chest, not in front, like across your heart. You don't want to do that because that'll inhibit their mobility of their one limb that they can move up front. And so you don't want to do that. It also causes some bandage sores because they are trying to move their leg. And it's just a nasty situation if they do get those bandage sores. So you can use them on pelvic limbs as well. It's just not ideal, especially in male dogs, because you have to cover up their penis and then they start urinating on their bandage, or you have to cut a hole in it, or you have to put a catheter in. So you can use them on femurs. Typically, it's a last resort. So what you'll need, like I said, a lot of cast padding. You'll need a lot of gauze. You'll need your fiberglass material that we just talked about. You'll need your cotton bandage tape, your elasticon, your waterproof tape. You kind of need the whole bandaging drawer for this type of bandage, and you're going to use a lot of each material. All right, so your patient's gonna be sedated because you are manipulating broken bones. So you're gonna want them in lateral recumbency with the bad leg up. You're gonna start placing your stirrups. I would still place stirrups on these bandages, even though they are incorporating a large part of the chest. So you're probably asking, like, how can it slip if it's attached to the chest? These dogs, typically dogs, once they start moving, any part of the bandage can start shifting, and I just add tape stirrups just to ensure that everything kind of stays in place to where I want them to be. Just basically going through the same motions. You're beginning to bandage below the paw with cast padding in your candy cane fashion, leaving the digits to be exposed upon the completion of the bandage so you can monitor for that swelling. All right. And then, like I said, you're going to need your assistant to help monitor sedation and also help lift the patient once you are applying that chest wrap. You're going to do a modified chest wrap. Like I said, you don't want to go in front over the shoulder over that other limb. You're going to want to do a figure 8 fashion around the trunk, dorsal to dorsal midline. What's important here is when you are doing these sedated chest wraps, your top layer, or what you can see on the top, is going to look a lot better than what you can see on the bottom. So make sure once your patient is up and moving that you are checking that other side to make sure that everything looks okay and is up to speed. Then you're going to wrap the cast padding caudal to the contralateral limb and alternating cranial and caudally to the affected limb. You want to go up, and then you also want to come back down, thus applying equal pressure throughout the entire limb. So just you're not wrapping in one way continuously up. You also definitely want to make sure that the chest strap you're applying isn't too tight, because obviously for obvious reasons. This is the part where you're adding the fiberglass. So you've already added all of your cast padding. Now the fiberglass that you're adding is going to be added a lot differently than how you just did for your fiberglass cast. This is basically going to look like a candy cane. You're going to be, when you create your fiberglass already and you've soaked it in your hot water and now it's nice and loose and soft, you're going to want to apply it in a line. You're going to fold it on top of each other and just create one big line, thick line of fiberglass. And then you're going to lay it on top of the bandage and his leg. And you're going to start at the bottom of the leg and you're going to fold it and mold it to the leg. So it's going to be a lateral splint for his leg. Then the patient's fiberglass is going to go up and over the shoulder. You want it to curve over, and this is what's going to give that humerus the support that it needs to be immobilized, right? We're going above the broken bone and offer the support. So you can't just have it stop there. It has to go up and over the chest. I believe that's what I said. Yeah, you're going to want to go start a little bit below the toes and then go over the shoulder. All right, now we're going to move on to that cling wrap. We're going to want to wrap it and lock this fiberglass into place. You're going to start wrapping it around, and just like you would a normal bandage, just kind of wrap it around and keep it in place. You're going to go up and then try and make it last to incorporate the chest. You want this bandage to be as uniform as possible, and you don't want to kind of separate it from the leg to the chest. You want it to be in one flow as much as you can, so that there aren't any spaces lacking in padding. After you do that cling, you're going to want to apply the vet wrap layer, and you're just going to do the same thing. What's important for these bandages is you don't want the vet wrap to be anywhere that cast padding isn't. If that vet wrap touches the skin, and it's in a mobile area, it can cause some serious bandage sores just from mobility and the dryness of the vet wrap. It can cut deep into the skin and cause bandage wounds. So just make sure that your cast padding is underneath all of your vet wrap. And then that layer is just the protective layer. There's no additional tension is necessary. Just kind of cover everything up and make sure everything is protected. And you can see in the front and the back of this SPICA splint, you can definitely see all the white of that cast padding. That's great. You just want to make sure that everything's kind of covered up. And then at the end of this part, you also want to go back and make sure that those toes are open so that the owners can monitor for swelling. All right. And here's a video of just how to make sure that those toes are open. Adding our soft padded, then we're adding our cling, and then I put my stirrups up, and then this is where you start the vet wrap. So the cast padding and the vet wrap start below the toes. Now you'll see I'm using my tongue depressor to get in between the toes and the bandage, and I'm opening up those toes to allow me to put some tape down in there. I pull back this tape. And I basically do that all around the bandage. This way, when you see digits 3 and 4, you can tell whether or not there's swelling or not. I tell my owners, if the toes are together, you'll see the nails quite close together. Once you start seeing those nails spread farther and farther apart, then you have an issue. That's when you have your swelling, and that's when that patient needs to be seen and treated as an emergent fashion, because that bandage needs to come off and be replaced. I want to make sure that no vet wrap is shown on the bottom of this bandage, because if it gets wet, that's a whole nother issue. So I want to make sure the bottom of the bandage is completely covered with my waterproof tape. And there you have it. You can see the toes. They're not walking on their toes. The patient's comfortable, and you can continue to do your job. this is how it should look. He looks great. His leg is immobile. He can move that left limb perfectly fine. Like I said, this shouldn't be a long-term fix unless absolutely necessary. So this patient should be pretty comfortable until they get to surgery. All right. I love me an external fixator, so this is one of my favorite sections. External fixator is usually used for fracture stabilizing, arthrodesis, angular limb deformities. Typically, it's used in younger animals, animals that their bones are still growing, and so you can't plate them because their bones are still growing. So we'll use an external fixator to stabilize the fracture from the outside, and then we can just remove it at the end. So this is how we're going to go into bandaging them. So immediately after surgery, we like to place a compression bandage because the leg is going to swell up. And when the leg swells up with an external fixator, it's going to bump into some metal. And then when the swelling has nowhere else to go, it's going to cause some serious wounds. So you want to place a bandage immediately after surgery. First, you're going to want to put some topical antibiotic, your bacitracin, your neomycin, your mupirocin, any kinds of those ointments to decrease microbial contamination, because you are exposing the inside of this dog or cat's leg to the elements by creating a whole bunch of pins into the leg. So once you have your contact layer on, then I like to apply non-adherent dressings, Telfa pads, gauze, just kind of give it that a little extra protective layer from the elements. I like to cut slits into the dressings to kind of fit, because you're going to have a lot of pins. You're going to want to squeeze them into these small little sections, so you can cut slits into your gauze or your Telfas to make them fit. Next, we're going to place the padding. Usually this is either like cotton or sterilized scrub gauzes. This is what's going to give you your cushioning. So when the dog's or cat's leg swells up, it's not bumping into that external fixator. So here I am pulling the gauze through. I like to use some needle drivers or something like, or mosquito hemostats, because you are moving into a pretty tight space. So I like to pull the gauze through in that aspect. Of course, stockinette, because I love me some stockinette. Makes it look nice and pretty. Make sure the top of the external fixator is also protected from bumping into this dog's upper limb. My gauze is in place, and then from this point on, we're going to treat this as a normal bandage. I'm going to add a stockinette donut just to protect that carpal pad, and then I'm going to wrap it and just kind of go around the external fixator as much as I can. I'm going to, at this point, I am treating it like a normal bandage. So I think we can move on from that video, since we've already kind of, adding a caudal spoon splint. Immediately after surgery, it just gives it a little bit of extra support. We probably only would do that for a day or two. And this is what it looked like. This is what that a different external fixator bandage looks like. It looks like a normal bandage that just has a weird bump in it. This is, believe it or not, a hind limb bandage that's in full extension after a fracture repair. It will not be symmetrical. It will be bumpy. It will look awkward. But this bandage is protecting all those wounds caused by those pins, everything else that goes along with the external fixator. You're trying to immobilize the limb. So these bandages are pretty important, and they definitely look weird, but they're pretty cool. All right, Ehmer slings. I love them. I hate them. They work sometimes, but when they do work, it's a very good feeling. The purpose of the Ehmer sling is to keep the hip joint in place after a reduction. What is the secret to a good Ehmer sling? I don't know. They're tough. They're tough. When I get this is probably one of the most common questions I ask. What's the secret? How do you do Ehmer slings? Honestly, it's a crapshoot. They're very strict situations that you need to have go right for you for these to work. But we're going to talk about some techniques that I've used that I learned from other people that I found to work more than others. So to be more specific, we're not using an Ehmer sling in a ventrocoxofemoral luxation. That should be treated with hobbles. It's very important that you know what kind of luxation that you're dealing with, because if you're treating it incorrectly, it's going to do more damage than good, and nothing's ever going to get done with that. So we are dealing with these craniodorsal coxofemoral luxations, not the ventral coxofemoral luxations. That's a tongue twister and hard to say, but it's important that you and your doctors know the difference. All right, the absolute best conditions for Ehmer slings. They're obtained in dogs with acute luxations, less than 24 hours. You want there to be little to no scar tissue surrounding this luxation. You want their temperaments to be amenable. If you think that you can put an Ehmer sling on a crazy Malinois dog, you're out of your mind. There's just no way. There's just no way. And you're going to need to have compliant owners. These bandages are going to need constant bandage care, and they're going to need to be activity restricted. So these owners need to be compliant. Contraindications, anything over 24 hours is a real stretch, but definitely greater than a week. It's not going to happen. You're lucky if you're going to be able to reduce that. Poor hip conformation, if they have hip dysplasia, it's going to be brutal. Dogs that are unable to ambulate the other limb, obviously, if there's an amputation or anything, if there's other injuries keeping them from using that far limb, you're going to want to avoid using an Ehmer sling. If the dog is obese also, or the cat is obese, that's also a tricky situation. They are useful post-surgery, just for a couple of days to prevent weight bearing. But if you're doing it before surgery, you want to avoid all those contraindications. I know that I'm a huge supporter of dog legs products. A lot of hospital uses their surge suits, their aural wraps. A lot of people don't know that they do make an Ehmer sling product that you can avoid all of this. I've used it a couple of times and I've had some pretty good success with it. But it is important to follow these guidelines. But I would also reach out to dog legs and see if you can get your hands on some, because it's an extremely important tool to have. All right, so this is talking about how to pop the hip in place. A doctor will be doing this, so you technicians don't have to worry about all of these words, but it is important to know kind of what they're doing. I will say this is what you should be doing, but when you see a doctor actually doing this, it's quite crazy, and sometimes if it's hard to get into, it can be a violent reduction of you're really trying to pop this hip back into place, and it doesn't want to go back into place at the end of the day. It's happy being out, and it's tough to manipulate this hip back into place. There's a lot of pulling and pushing involved. To get started, it's super important that you take these hip radiographs before even starting anything. You want to know what kind of luxation you're dealing with, and you want to make sure that you will be able to pop the hip back into place. So basically what they are trying to do when popping the hip back into place is you're externally rotating the affected limb while simultaneously providing the distal traction to the limb and counter traction to the inguinal area. So you're really like trying to move around while pulling and pushing different types of the limb to pop that hip back in place. And then while the traction is maintained, the limb should be internally rotated and simultaneously distal pressure to the greater trochanter applied to facilitate reduction. After all of that pushing and pulling, if you are able to reduce it, you want to take another radiograph. You want to confirm that it's back into place before even attempting to put an Ehmer sling on. These radiographs should be done gently. I know beforehand you're kind of pulling, you want the limbs to be straight, so you're pulling. These second sets of radiographs should be gentle and minimal to no pulling whatsoever. So what you'll need for your Ehmer sling is some cotton cast padding, not nearly as much as you needed for your SPICA splint, and elasticon. Here's just a picture guidance of kind of what we're going for, but we have a video that this video is actually the one that I use to learn how to do an Ehmer sling. I don't have my own video, but I hope that it's helpful for you guys too. So this video is done on a cadaver, and she does a really good job of explaining how to manipulate the hip and lock it into place. Basically, we're going to be doing a figure 8 wrapping, but we're going to do it so this bandage never goes I'm sorry, I didn't want to interrupt her if you guys can hear her. She's talking about internally rotating the knee. So you're trying to keep that hip in place, but also immobilizing it at the same time. So you're going to start wrapping your cast padding, and this is just to avoid bandage sores on the foot because this is where the most motion is going to be. So just do a couple of passes with your cast padding. The rest of the bandage is primarily going to be your elasticon. And this is where it's tough to be gentle. You want to be extremely gentle while doing this procedure so you don't pull that hip back out of place. So you're going to want to pull out the elasticon a decent amount beforehand. You don't want to be pulling it while you're holding on to the limb. You start by folding it a little bit over and then attaching it to the elasticon. I like this technique better than wrapping the elasticon a couple of times. I just think it's a little more violent doing that, and this way is just a little less mobile for placing it. So now you're going to kind of pop that hip up and then go above the femur and into that inguinal area, and you're going to come back down. You're going to go behind the hock and twist it, and then attach it back to where you started. You'll notice that the elasticon is never going above the tibia. It's only going above the femur and that hock. And then you're just going to repeat the same thing. You'll notice that she's holding the elasticon in place while she's pulling on it, just to make sure that it's not adding too much pressure on that hip. Once you're done rotating, then you just go over the hip, and this just gives it a little extra more stability and helps keep it on. And then that's your Ehmer sling. Like I said, you guys could do this, or Dog Legs makes a product. I would definitely check them out. It'll make your life a lot easier. It'll have less bandage sores and a lot easier to apply. All right, so one of the coolest things with wound care is when you get to use one of these bad boys, the vacuum assisted closure or VAC system. These are for your big wounds, your deep wounds, your the wounds that you want to close, but you can't suture them together yet. It's too tight of tension. VACs are amazing because of just everything that they offer. They decrease air pressure on the wounds. They gently pull fluids from the wound over time. It reduces swellings. It cleans it. It removes bacteria, helps pull the edges of the wounds together, and it stimulates the growth of new granulation tissue that help the wounds close. These things are awesome. I like them from a specialty surgery perspective. ER technicians will tell you that they hate them because they're constantly clogging. They're constantly beeping. They are constantly going off, and they're just annoying. But I love them because they definitely get the job done. So let's get into talking about those. All right. So the under placement, they will always be, just like any major wound care, they will be sedated, they will be anesthetized, and they will, you'll basically clean the wound, take off necrotic tissue, and then you'll pack the wound with the foam dressing. And then you'll want to suture it in, and just we like to add staples as well around those to just make sure that the foam dressing locks into place. Typically, these patients stay in the hospital for a couple of days, just because, like I said, they clog. They just have a lot of decent amount of maintenance issues that need a technician there constantly monitoring it. So the patient is usually hospitalized for a couple of days. These days, they do make more portable VAC systems that are pretty owner compliant. I haven't had any personal experience with them, but I've definitely read up on them, and they seem to have some pretty good reviews. So that is an option. It's just usually there's some serious wound care going on. So I think our hospital prefers to keep it in the patient in-house, so they can just keep an eye on them. And 4 days. 4 days is the max because the granulation tissue, if it starts growing in, it will attach to that black foam dressing. And so when you take the vac off, you do not want to take all the granulation tissue they worked so hard to get in. You don't want to debride it when you take out that foam. So 4 days is usually the maximum amount of time that each vac can stay on. All right, this is a video of a vac placement. This is pretty cool. This was my favorite wound case of all time. So please enjoy this vac placement video that I've done. So this dog, if you've been following Brian's Bandages, you've probably heard of this dog. This is Cyrus. He was had a run-in with a bobcat where he pinned a bobcat down and bunny kicked and the bobcat bunny kicked Cyrus's chest, leaving him with his entire chest just sloughed off, and left him with just open wounds that we had to place the vac. I think we did 2 rounds of vac treatments on Cyrus. So here the doctor is suturing everything into place and then also stapling it into place to make sure that it doesn't move. So he had the one major wound, and then we were able to close it down to these 3 other wounds on his chest, the one in the arm, and then the 2 up top. Those 3 wounds were connecting, but the big wound didn't connect. So what we had to do was we had to add a tube. We just used a red rubber to connect the two areas so that we only had to use one vacuum system on him. And so all the air was connected with that one tube. Contraindications for this would be if you aren't able to, like I said, these patients have to be sedated for or kept in a hospital for a couple of days. Cost is a huge concern with these treatments just because they do have to be hospitalized for so long. And then just like a SPICA, we talked about their contraindications, the Ehmer's contraindications of being a crazy dog. And then fiberglass casting even has contraindications where if it's a open fracture, if it's there's a skin condition that requires airflow, or just an open wound, you really don't want to lock in all of that. You want the wound to be able to breathe, and you don't want to cover that up with a fiberglass cast. So like you saw, he covered it in saran wrap and kind of just takes away all the airflow, attach the vac, and then once you turn it on, you can see it suction down. And it's my favorite part. It's so cool. And then now you have a vacuum system where the machine is constantly sucking out air, debris, necrosing tissues, and it's doing all the work for you. So it's a super cool wound management case. It's just pretty expensive to deal with. So it's very awesome that these owners were able to do this for this dog. All right, thank you for joining me. Does anyone have any questions?
I'll give you guys a second to go ahead and type. Just use the Q&A to the left of the screen. Okay.
Yeah, if not, you can always send me a message on Facebook or anything like that too, if you think of something.
Yes, and his email is brian@vetmedology.com as well. So let's go over our upcoming live webinars, February 2024. On the 15th, we've got the Complete Guide to Medical Math for Emergency and Critical Care Veterinary Medicine by myself. March 2024, we have ADHD and neurodivergence in veterinary professionals for leadership and support staff, a partnership with leading veterinary teams in vetmedology. And in April 2024, we have the Phone Triage Masterclass with Dr. Shadia Rayfedge, boarded surgeon and CEO and founder of Vet Triage. To earn your certificate tonight, go to www.vetmedology.com and create an account or subscribe to Vetmedology for just $10 a month. Navigate to the Your CE portal, and this webinar will be available to you by tomorrow, likely tonight, to complete the required quiz to earn your free certificate of completion by no later than Saturday, the 3rd of February at midnight if you are not a subscriber. If you're not a subscriber at that time, you will lose access to the course in the Your CE portal, and Vetmedology subscribers receive free access to all live webinars. Okay. All right. Well, thank you all so much for joining us tonight. Thank you so much, Brian.
Yes, thank you for joining us, everyone. I hope you learned at least one thing.
Yes. All right. Have a good night, everybody.
Care.